In today's episode, we're going over a case study of a patient post-operative ACL reconstruction, and we're also going to go over her pre-op rehab. Let's get it rolling. First and foremost, thank you so much for watching and supporting me. You truly allow me to do what I love for a living. My name is Dan Pope. I'm a physical therapist, coach, meathead. I love all things fitness tremendously. It's been my biggest passion since I was a little guy, right? This is the Fitness Pain Free Show where we help coaches and physical therapists like you get your patients out of pain and back to training. If you're watching this on YouTube, please hit that like button. It helps me out tremendously. It sounds really stupid. And, when I am watching YouTube, I very rarely hit the like button. I should more frequently because it helps me out. Okay. Please comment if you have any questions, and then subscribe to the channel if you haven't already. And then if you're listening or watching this via podcast, yes, there's a video podcast up on Spotify. Please leave me a positive rating and review. That, again, helps me out tremendously. If you want to go that extra step and support me further, consider subscribing to Insiders. It's a comprehensive educational resource and toolkit for the fitness and rehab professional. Think Netflix, but for trainers and physical therapists. It's premium content from me. I've been updating this for 5+ years. There's over 100 webinars, ebooks, and complete guides. You have access to a private Facebook group. So if you have any questions, I'll answer those. You can also decide upcoming podcast topics. I've gotten a lot of really good topics from you guys over the course of time, which has been a lot of fun. And you get started for just $1. It's kind of ridiculous how cheap it is, right? I'm probably going to bring that price up in the future. And you can cancel anytime. So if you're interested, I'll put a link in the show notes, but you can also go to fitnesspainfree.com, go to programs, and click on Fitness Pain Free Insiders Online Library to get started. Before we get started today, I want you guys to download the evidence-based guide to exercise after ACL reconstruction. So I'm in a really nice infographic that's going to help you out with all of your patients when you're trying to figure out which exercise to give them and how to advance them over the course of time. I'll put that link in the show notes. We go over why do we care about exercise selection after ACL reconstruction, how to dose exercise for ACL reconstruction patients, and also when is it safe to start open chain knee extensions, okay? So link in the show notes, definitely check that out. It's going to help you out tremendously, okay? Free resource, go grab it. So who are we working with today? So this is an older patient of mine, and I'm actually still working with her. So we haven't gotten through all of her rehab, okay? So when I don't have information on her rehab, right, when we get to the very end, it's because we haven't done it yet, okay? Hopefully at some point in the future, we can do the entirety of her rehab, but right now you're going to see up to week 14. So she's a 54-year-old female, and she's a recreational cyclist, right? Very, very fit. One of the reasons why it shows her as a case study is because you're not always going to be dealing with ACL reconstruction for folks who are trying to get back to soccer. And I think the rehab ends up being a little bit different. So we're going to talk about how we did her rehabilitation, okay, and how it may change if she was trying to get back to, let's say, some sort of higher level basketball, soccer, field hockey, anything along those lines. However, she is very fit. Okay. And she wants to get back to a lot of activities, probably the toughest of which is going to be skiing. So she actually has a home out in Colorado. She goes there for most of the winter and does a whole lot of skiing. All right. But she loves cycling. She does a lot of very long distance cycling. She's also into yoga, bar, group fitness classes, as well as hiking. So the forces the knee have to be able to handle. Eventually, we have a good idea of what they are. So we can just work our way up there over the course of time, and just going to show you how we do it. So I like to think about people's activities in terms of seasons, right? This makes a lot of sense if you're thinking about a sport, right? So if you are, let's say, baseball, you have more of a spring sport, right? If it's more like basketball, it's more of a winter sport. We can kind of plan around the year that way. For her, her competitive seasons are in the summer for cycling, right? She actually hurt herself in winter, right? In March. So we can kind of plan around this upcoming season. And then she also likes to ski a lot, which occurs in the winter, obviously, right? So this becomes relevant because when we're returning back from ACL reconstruction, we have to think about the amount of time that we've had. And we also have to make sure that people rehab appropriately. We can kind of prepare the person for when they're going to be able to come back and kind of say, like, it's too early for you to do this next ski season, but I think the next one will be fine. But this upcoming cycling season will be okay, right? And we'll chat about this in the future. What are some psychosocial things about this patient that I think are relevant? Well, for one, she's very, very willing to work. She's absolutely dedicated. And she's one of those folks that kind of loses her mind if she's not able to exercise, which I actually really like those patients because they're willing to put in the work. What that also means is that sometimes you have to pull back because they're pushing a little too hard, right? So if someone is pushing too much, they're getting painful, swollen, you think they're doing too much, maybe damaging that graft, you have to pull them back, right? And for this patient, that was one of those things we had to talk about just because exercising is great, but you can certainly overdo it, right? The other piece I think was relevant is that she's not a huge weightlifter. You saw her list of activities she likes to do. Weight training was never, one of those. I always try to sell people on the idea of adding some sort of weight training into their recreational fitness, just because we know the positive benefits, right? Life extension, muscle mass, fast twitch muscle fibers, bone density. There's so many phenomenal benefits. I really think everyone should be doing some sort of weight training. Okay. So I sell these folks to try to start obviously with the rehab, but also to continue on into the future. Right. However, we're going to have to coach her up quite a bit because she's been involved in a lot of fitness and she actually picked it up really quickly, but not like she's been weight training for the past 20 years and knows how to do the movements perfectly. Right. So it makes a difference with the rehab. So she had a left knee injury. This occurred while she was skiing. It was a twisting injury, right? So twisted on that knee, felt a pop, knew something immediately was wrong, right? She had immediate swelling. So she noticed right away it started to swell up, right? And oftentimes, if someone has immediate swelling, we start to think maybe that's more ligamentous in terms of the types of injuries. If it's delayed, then sometimes we're thinking more of meniscus. However, this can be very different from person to person, so it's not always perfect, right? And at the end of the day, we get an MRI just to see anyway. So she also had a very immediate reduction in range of motion, which is a red flag. So something's wrong. She needs to get some imaging and figure out what the heck is happening. So we got some imaging, and what did it find? Well, there it was, ACL tear, right? On top of that, she had some meniscus pathology, right? And it was a bit of a question about the next steps here, just because oftentimes when you're looking at meniscus pathology, it could be more degenerative in nature or it could be more acute. Obviously, the acute stuff is more reparable generally, right? I have a whole podcast on how to look about meniscus tears and which ones need to be repaired. If you look back into Fitness Pain Free Show episodes, I forget which one it is, but if you want to learn more, definitely check that out. So you can also have what's called an acute on chronic meniscus tear. So let's say you have an older meniscus tear from, let's say, wear and tear or degenerative changes. You can have a new meniscus tear on top of that, right? And sometimes that could be operated on, right? Sometimes not. So it becomes this decision-making process, basically for the surgeon, not for me, not for the physical therapist, not us, obviously, right? But do we try to repair the meniscus? And generally speaking, yes, you try to repair it if you can. Or should you have a meniscectomy or just leave it alone, right? And the surgeon that she worked with actually really trusts him. I think he's a great doctor. We actually recommended him. He said it's gonna, depend on what he sees once he opens up the knee joint. So what happened is that she was prepared for either surgery, so the meniscectomy or the meniscus repair with the ACL reconstruction, and basically that would affect future rehabilitation, which we'll talk about when we get to that section. So, kind of bringing us to the same point we were just chatting about, this is a shared decision making process. What does that mean? We make the decision on the type of surgery between the patient, right? So, patient first, as well as the physical therapist and the surgeon. So, lucky enough, she came to us first. She was referred from a friend. So, that's always great. So, that means that you will inherently get some more trust from a patient like that, right? And we actually recommended a surgeon that we really, really like. And she ended up going with that particular surgeon, what I think is good. And there were some decisions to be made, right? So should you have a surgery, right? Or should you not? And I think the big decision-making factor there was she wanted to get back to kind of a change of direction sport, which is basically skiing, right? All the other activities, you can make the argument that maybe you go without it. And if you're noticing you don't have the stability that you want, maybe you go down that pathway of getting the ACL reconstructed, right? But for the activities that she wanted to get back to, we thought that the ACL reconstruction was her best option, okay? We also had to figure out what was going on with the meniscus. So it's that same decision-making process before. The surgeon's going to open up the knee, see what they find. If they can repair something, great. If they can't, then they'll just do a debridement, meniscectomy, or they'll leave it alone, right? The next big decision to make was graft selection, right? So we have a choice of either an autograft, so usually that's the patellar tendon or the hamstring tendon, or an allograft, which is going to be a cadaver graft, right? So a couple pros and cons of each of these. So the allograft tends to be a faster rehabilitation, right? That's one of the reasons why surgeons end up liking this. However, the allograft is more likely to re-tear or fail, right? So despite the allograft having a faster rehabilitation, what I mean by faster rehabilitation is people feel better quickly, right? Because you don't have to take out their hamstring tendon or their patellar tendon. So you end up feeling better much more rapidly, okay? Which is nice for someone who's not necessarily trying to get back to a professional sport, right? If this re-tears, it's obviously a big issue. So a lot of folks won't go down the route of allograft because there's a higher re-tear rate. Okay. But again, keep in mind her age. She's in her mid 50s. She's liking to do some skiing and a lot of fitness, but she's not going crazy. She's not going back to a professional sport, right? So she ended up opting for the allograft over the autograft just because the auto is a much more challenging rehabilitation from a pain perspective. You get quite a bit weaker because you end up taking the hamstring tendon, patellar tendon, ends up being harder. Doesn't mean that ultimately it can't be a great choice, but at the end of the day, she ended up deciding on the allograft or the cadaver graft, right? And the second question was, when do we have surgery, right? And we'll chat a bit about this, but there's quite a bit of research that shows if you restore your range of motion, if you get rid of the swelling, okay, if you increase the strength, and if you work on neuromuscular control, that's going to allow you to have better long-term outcomes. So a year after you've had ACL reconstruction, if you did pre-operative rehab, okay, and regain your quad strength, you do better a year following your surgery, okay? And that's actually very, very important. The other decision to make is that we're kind of trying to plan around her seasons, right? So ski season is a major one. And she got hurt, I believe, in March. So we look for, let's say, 9 to 12 months of rehab before going back to a given sport. And for her, since she had an allograft, sometimes you want to wait a little bit longer just because they have an increased incidence of re-tearing or failure, right? So for her, we decided to get this thing repaired ASAP. Repaired is not the right word, reconstructed ASAP once she had her strength and range of motion back, which you'll see we did get that. But she's going to miss this upcoming winter ski season. We talked about this. We said, I think it's best for you and your long-term health if you just do your rehabilitation, really well and skip this upcoming ski season. And she was okay with that, right? It does stink for her, obviously, but I think that was the best long-term decision. So let's talk a bit about her training age, right? So she's actually been training for around 30 years, right? But mostly fitness, okay? As I said previously, she doesn't have a large history of weight training, and she was never a typical athlete, right? It's not like she played a ton of sports all through high school, college, and afterwards continued to play at a professional level or anything like that. She just loved fitness, okay? Which is phenomenal for us because it makes it quite a bit easier because rehab tends to be very similar to a fitness routine. So if you had a fitness routine going previously and she loves fitness and wants to get back to it, makes it quite a bit easier to sell that exercise upcoming, right? Her goals are basically to make the best long-term choice, right? So what's the best surgery? What's the best rehab decisions, right? What's the best graft we can use? I want to make sure I maximize my long-term health. I'm willing to forego a potential season of skiing as long as we do this as well as possible, right? However, with that being said, she wants to get started ASAP. She loves her fitness and she's going crazy not being able to do it, right? And her goals are return to skiing, cycling, and her other fitness activities that we just discussed. So next, we're going to talk a little bit about the pre-operative prep. So we ended up seeing her prior to surgery, which is phenomenal. If we can do that, we want that, right? And I want to share a little bit of research. This study was from, let's see, Falia et al. And the study name was, Does Extended Preoperative Rehabilitation Influence Outcomes 2 years after ACL Reconstruction? This was AJSM 2016. And basically what they did was an additional 10 sessions of physical therapy after someone had torn their ACL, but prior to reconstruction, okay? And their criteria for having surgery was full range of motion, swelling was down, quad lag was gone, and then they had 10 visits, extra visits of neuromuscular training, which is basically perturbation training. Imagine standing on a Bosu ball, passing a ball against the wall while someone tries to mess around with the Bosu ball. So you have to maintain your balance, right? And what's really cool about this is they showed better outcomes, right? And return to sport at 2 years after surgery. Now, this is phenomenal. So we can have a tremendous impact on improving our ability to get back to sport and our outcome in general by doing more prior to surgery. So whenever you can, I really recommend you get your patients do some pre-op physical therapy before they go on to get surgery, okay? So in terms of pre-op preparation, what are our goals, right? So this is taking directly from Delaware's ACL protocol. It's my first reference. If you guys are looking for a really solid ACL reconstruction post-op protocol, I would recommend checking that out, right? So I'll put the link in the show notes. Again, it's my first reference too. So the phase goals are to begin as soon as possible following the initial injury to reestablish the following goals prior to surgery. So we're looking for full active range of motion and passive range of motion of the knee, okay? Get the range of motion back. We want that knee flexion range of motion within 10 degrees of the uninvolved limb. So basically, if you don't get the flexion back 100%, that's okay, but we're looking to get pretty close, right? We're looking for trace to zero knee effusion, right? We don't want to push folks too fast into surgery when their knee is swollen. We're looking for no knee extension lag with a straight leg raise. We're looking for quadriceps strength index greater than 80% of the uninvolved limb, right? And we want to retain these values for post-operative comparison to minimize overestimation of strength, okay? So what this means is that, let's say if you're looking at left versus right strength right after an injury, right? And if you have an ACL tear, that side is probably going to be a bit weaker, right? But the contralateral limb is probably quite strong still, because it's not like you just tore an ACL on that side. So if you check the strength of the uninjured side, okay, you get a baseline level for what your strength is at. And as you start to progress through rehabilitation, what happens is that you get a bit weaker initially because you can't load that contralateral limb quite as much, which we'll talk about this. You actually can do it quite a bit. But then when you retest in the future, you want to know what the strength was prior to the injury or prior to the surgery if you can, okay, on that contralateral limb. So you have a good idea of what you want to get the surgical side back up to, okay? So this is a period of time where you're gathering data about strength, right? Not just on the surgical side, but the non-surgical side. And I also like to test other areas besides the knee. So it's a good time to test, let's say, knee extension, knee flexion, but maybe the hip abduction, maybe hip adduction, calf strength, whatever you want, right? So this is the time to gather that information. So what are the key points that we went through in our pre-op PT? So one, we want to restore range of motion. The extension range of motion is a little bit more important than flexion range of motion. Okay, we'll talk about how we did this in a minute. We want to reduce swelling. Oftentimes, this ends up being activity modification. So we want to do enough activity, so we're kind of pumping that swelling out of the area. We also want to make sure we're not doing too much standing and walking, so the area gets extra swollen. Okay, so it's kind of this dosing approach to get swelling down. We want to add compression, elevation, ice at day's end, right? This is a little bit mixed in terms of the data out there. So go ahead and go down that rabbit hole if you'd like to, but this is something that we use generally. And I also just like using compression garments throughout the course of the day. Okay, I think that could be helpful for swelling. The next thing we want to do is restore quad strength. And this is going to be neuromuscular control. All right, so actually getting that muscle to fire well, as well as true strength. Okay, and the two are actually related. We also want to try to reduce atrophy so you can measure that quad prior to having the surgery to see where it's at. And you can actually measure it throughout the rehabilitation process to see how you're doing. We're also trying to work on neuromuscular control, as we talked about earlier. For me, neuromuscular control is a fancy way of saying balance, right? We work on a lot of balance drills that are progressively harder over the course of time. We're working on proprioception. So again, same balance. And then strength and motor control, which a lot of these are related, but you'll kind of see how we did over the course of time, okay? The other thing is we want to try to maintain our fitness and strength elsewhere as much as possible, okay? It's very hard to build up strength and conditioning. It's much, much easier to maintain this, okay? So as much as possible, while protecting the injured area, we're going to try to maintain our strength and maintain our fitness, okay? So what this does mean is we can strength train the crap out of the contralateral limb. Single-legged squats, single-legged deadlifts, all that good stuff, okay? We can also train the rest of the kinetic chain. So the core, the upper body, right? We can train the calves. We can train everything, right? We can train everything within the system that's not putting too much stress on the injury site, okay? In terms of physical therapy frequency, pre-op, I saw this patient 1 time per week. I felt that was largely adequate. I don't feel like she would have gotten a whole heck of a lot more out of additional visits. Unless she was very restricted with range of motion, which she wasn't. Plus, she was very, very good at her range of motion at home. So I didn't recommend more because I think she was doing just fine. Okay. However, I do give a very in-depth home exercise program. She's doing something daily, every single day, on top of a strength program that's usually 3 to 5 days per week. Okay. So how do we work on restoring range of motion at the knee? So when she comes to physical therapy, we're trying to restore extension range of motion first. So I'll start out by doing soft tissue work, right? Massage, cupping, tool work, whatever you want to use, to the gastroc as well as the hamstring. Reason being is because if these are guarded, right, tight, whatever term you'd like to use, then it's going to restrict extension range of motion. So we start off with that, okay? When we're trying to restore flexion range of motion, we work more on the quad, right? Also keep in mind that one of the reasons why folks are limited is probably because they're swollen, all right? So if you're trying to do potentially some effleurage, get some of the swelling in that area, that may be beneficial as well. After this, we follow it up with some patellar mobilizations. So mostly inferior and superior. So a superior mobilization is going to help with extension, and an inferior mobilization theoretically is going to help more with flexion of the knee, right? And then I follow that up with range of motion drills, right? So if I'm trying to work on extension, generally I have someone lay on their back, supine, I'll prop up their heel, right? And then I'll try to press above the kneecap straight down, right, to extend the knee, okay? And if I'm trying to flex the knee, usually I do that seated on the edge of a table, and I'll just bend the knee back and forth, okay? So pretty basic, pretty easy, but tends to be pretty effective. In terms of exercises for these folks to do on their own, right? I am a big fan of adding constant, very frequent, low intensity motion to restore range of motion. Okay. And the biggest priority is going to be extension. I tell my patients that. So I actually have them do quad sets, terminal knee extensions, assisted extensions. So basically having your leg straight, pushing your knee down yourself. And I tell folks to do this 3 to 5 times a day, every single day, up to every hour, as long as you're not getting too painful or swollen. So if you're pushing the range of motion too aggressively, your body will kind of revolt a bit. It'll start getting really painful, more swollen, all things that we don't want. So we kind of dose the amount of range of motion exercises based on how much they need it, and also based on how much swelling or pain they're getting, right? We want to make sure they're getting better over the course of time and not worse, right? The other thing that can be very helpful for folks, especially limited with extension, is a low load, long duration stretch. So I stole this directly from Lenny Macrina, but this is all over the medical literature if you want to read more about these. Basically, you lay on your back, you prop up the heel, and then you put an ankle weight above the kneecap, not directly on the kneecap, because that could be a little bit irritating. You start with a nice light load, and you let that stretch out the knee into extension, starting with about 10 minutes or so, but you can work your way up to 60 minutes if someone is really, really stiff. Okay. For this patient, she didn't need a ton of this. I think she ended up doing this once per day, mostly because she's an all-star patient and she wanted to push it a little bit more, which is phenomenal, but she didn't need much more than that. So do keep in mind that some folks will need more of this. Some folks maybe not. Just make sure you're constantly reassessing over the course of time. So what do we do for flexion? Well, it's a similar idea. It's constant, frequent, low intensity motion, right? So you're doing a lot of exercises like heel slides, seated knee bends, and then chair knee bends, right? What I tell folks generally is that pick the exercises that are most comfortable and convenient that get the job done well, okay? So if you're working all day long and you're sitting a lot, then probably a seated knee bend is one of the best things you can do, right? If you have the option to lay on your back and do heel slides throughout the course of the day, and they seem to help the most, then do those, right? So we choose 1 or 2 exercises that work the best, and we do this 3 to 5 times a day, 10 to 15 repetitions or so, and we just watch for swelling and pain, right? So if we're creating more swelling, more pain, and we're actually reducing our range of motion because we're doing too much, that's no good. So you have to make sure that you're watching that over the course of time and making sure it's actually getting better and not worse. You may have to increase the frequency of exercise, or you may actually have to decrease depending on how much pain and swelling you're getting. So next, let's talk a little bit about the quads, right? In the physical therapy world, after people have an ACL reconstruction, the quad is like God's, right? It's so freaking important. I want to talk a little bit about why it's so important. So this study right here is from Kim et al. This was from, what year is this? 2022. Pre-operative quad muscle strength deficit severity predicts knee function 1 year after anterior cruciate ligament reconstruction. So this is super interesting because if you have weak quads going into your surgery, right? So if you're weaker in your quad muscle prior to going in for ACL reconstruction, you're going to do worse 1 year after surgery, right? So the quad strength you have prior to surgery is incredibly important for your long-term outcome, okay? You have some work to do prior to getting the surgery in order to have the best outcome, okay? So better quad strength is going to improve outcomes long-term, right? It's also going to improve return to sport rates. Okay. And that's also very important, especially for folks trying to get back to a sport, right? And the other piece is that the quad is generally the weakest area following ACL reconstruction. The reason why we harp on this so much is because there's a ridiculous amount of information out there showing just how weak this thing is after folks have surgery. Okay. So we have to make sure that we're diligent in improving this prior to surgery and then after surgery too. Here's another pretty interesting study here. This is from the Journal of Science and Medicine in Sport from 2016 from Thomas et al. Title of the study was Muscle Atrophy Continues to Contribute to Quadricep Weakness After ACL Reconstruction, right? And basically what this is showing is that in folks that have atrophy, right, of the quad, they also had weakness, Okay. And there's a pretty tight correlation. This may sound like a no brainer, but one of the biggest things we're trying to do is improve strength. And we need to do that probably through improving the atrophy as well, right? So you have a smaller muscle, it's probably not as able to produce force over the course of time, right? And if you've ever worked with a post op ACL, you'll know the quad is like a bowl of mashed potatoes after the surgery. It just doesn't fire well at all, right? So part of what we're trying to do is to restore that neuromuscular control. So basically getting that muscle to fire well, right? So it doesn't feel like mashed potatoes when you push into it and try to flex at the same time. And over the course of time, we're trying to build back that hypertrophy or that muscle mass, right? And with it is probably going to come that strength. Okay. The last thing to keep in mind is this is actually a little bit sad, but in folks that have ACL reconstruction after surgery, their quad is at, let's say, I don't know, 20 inches. That's going to decrease over the next few weeks. So after you have surgery, you will continue to get atrophy for several weeks after surgery. Okay. Now, there are a few things we can use to attenuate this. One of the biggest ones is blood flow restriction training, which we'll talk about in a bit. But keep in mind, surgery is going to make you weaker, and you're actually going to continue getting weaker for weeks after you've had ACL reconstruction. Okay. So you get weak after you've had the injury, right? Hopefully you build that back up a little bit. Then you have surgery and you get weaker again. All right. So you're dealing with this double whammy where the knee is getting hit twice, once with the injury, and then it's getting hit again with the surgery. So you've got this mountain to climb back in terms of quad strength over the course of time, right? So our next big goal is to restore strength of that quad as much as we're able to. And this little stat here is coming directly from IJSPT in 2020 from Charles et al., a systematic review of the effects of BFR training on quad muscle atrophy and circumference post ACL reconstruction. And what they said, which I thought was really impactful, is that compared to the contralateral limb, discrepancies in knee extensor strength can be as high as 30% on the surgical side 6 months after surgery. The difference in quadriceps cross-sectional area between the contralateral and surgical side is as much as 18% after 6 years. Okay. So 6 months after ACL reconstruction, which used to be a period of time where folks were getting back to sport. And I know a lot of docs will still recommend getting back at the 6-month mark. Your deficit could be as high as 30%. Then 6 years after surgery, you may still have a 20% deficit in muscle mass on the quad, right? This is crazy, right? So this is why we're so hell-bent on getting that quad back, both before surgery and then after surgery, okay? Because the quad is super important for outcomes, and we tend to have a lot of weakness, right, and a lot of atrophy after surgery. This was another super interesting recent study in 2021, the European Journal of Applied Physiology. This is from Minshul et al. Contralateral strength training attenuates muscle performance loss following anterior cruciate ligament reconstruction, a randomized controlled trial. Now, I do believe you should strength train your contralateral limb, right? Your contralateral limb is actually quite important. Again, we want to try to maintain the strength on that side because we are going to get weaker on that side as well, just because you can't strength train quite as much right after you've had ACL reconstruction. So I want to make sure that we're maintaining the strength on that contralateral limb, right? So that's going to mean working the hamstring and the calves, right? We're working the kinetic chain because those are important. And what this study was showing, and this is kind of crazy, but just training that contralateral limb is going to attenuate a lot of the hamstring and quad weakness in the short term, right? So basically, at 10 weeks in, after ACL reconstruction, in the group that ended up working the contralateral limb versus the group that did not work the contralateral limb, the folks that worked the contralateral limb didn't have the same amount of hamstring and quad weakness as the folks that didn't work the contralateral limb. What does that mean? It means that training the contralateral limb actually makes the surgical limb stronger, and that sounds crazy, right? But it seems to help in the short term. So at 10 weeks, but at 24 weeks, a lot of this went away anyway. But however, I still think it's really smart to make sure that you're working the contralateral limb, especially working the rest of the kinetic chain, right? And we just made a huge deal about working the quadriceps, and that's obviously important, but we also want to make sure we're working on the hamstrings and the calves. As I discussed in my last lecture, we talked about evidence-based guide to ACL reconstruction exercise prescription. There's a very important co-contraction that goes on between the quad, the hamstring, and the gastroc that's going to reduce stress on the ACL graft. So we obviously need to make sure those are nice and strong. Okay. The hips are also important because in a lot of folks get injured, they don't have great control of valgus at the knee. and they end up getting injured as a result, right? And the other piece is that you may have a partial weight bearing status. And if you have a partial weight bearing status, which we had in this patient, they're probably going to end up being a little bit weaker than someone who had full weight bearing status just because we can't load that limb quite as much. So we got to train the rest of the kinetic chain as much as we can, even though the quad is probably the most important thing. The next goal we had was to maintain conditioning in our patient, right? And this study is really interesting. It's called Preseason Aerobic Fitness Predicts In-Season Injury and Illness in Female Youth Athletes, okay? This is 2017, my Orthopedic Journal of Sports Medicine. It's Watson et al. I know what you might be saying, right? This is, small sample size, and it was female youth athletes, right? Which is not going to necessarily carry over to every single sport and every patient that you're working with. But what I thought this is really interesting is they were looking at athletes' VO2 max, right, as well as time to exhaustion, and they are testing. And what they found is that these things were protective, right, against injury. So if you had a really high VO2 max and you did really well in the time to exhaustion test, you were less likely to get hurt when you went back to your sport, right? Now, we want to try to maintain our fitness as much as we can. Like I said previously, maintaining fitness is a lot easier than trying to build it up after you become really deconditioned, right? So after ACL injury and prior to surgery, and then after surgery too, we want to try to maintain our fitness as much as possible. Now, one of the reasons why I think this is really important is because this is clear evidence to show that, we need to probably focus on this, but I don't think it's very often on a physical therapist's radar. After someone has ACL reconstruction, you might, have them go on the bike 15, 20 minutes prior to every session. But, we don't think about higher level return to conditioning generally until someone's getting to like 6 months or so. If they're lucky, a lot of folks don't even get PT after the 6-month mark, right? If their insurance is not covering it. But trying to maintain and build conditioning over the course of the prehab, prior to surgery, as well as afterwards, is vitally important. And I think as physical therapists, we need to make sure this is on our radar and we're thinking about this because if a person's not fit, despite being strong, right, and landing well and all that good stuff, they may be more likely to get re-injured. With ACL reconstruction, obviously, we unfortunately are not the best at rehabbing these. People tend to re-injure at a relatively high rate, which is not phenomenal, right? So anything we can do to reduce that likelihood of injury is probably worthwhile, okay? So I start doing conditioning as soon as it's safe and or appropriate. We'll talk a little bit about this. But the other part that is important is long-term planning, right? So if you have an individual that doesn't need to do conditioning at the moment because their season starts in, let's say, 3 to 6 months, then don't hammer the conditioning if it's not the time of the year that they need it and or they already have good conditioning, right? So we have to keep in mind that we want to make sure that we're not just conditioning for the sake of conditioning. We have a conditioning plan that's in line with the entire year's training goals, right? So that's going to be important. If you guys want a very, very in-depth guide to exercise prescription and progressions for knee pain, like ACL reconstruction, but as well as patellofemoral pain, meniscus pathology, and a couple others, then definitely consider subscribing to Fitness Pain-Free Insiders. Inside of there, I have a lecture called Exercise Prescription and Progressions for the Knee. We go super in-depth on where to start exercise-wise and how to progress over the course of time, how to know when you need to pull back, when you have to pull forward, the differences and the nuances between different pathologies. I go super in depth. So I'll put a link in the show notes to check this out, fitnesspainfree.com. Click on the programs link, click on Fitness Pain Free Insiders online library, and check out this exercise prescription and progressions for the knee lecture. Great next step for learning more about exercise prescription and knee pain. If you guys are interested in any of the references, I'll leave that in the show notes as well. Reference number 1 is that Delaware ACL Reconstruction Physical Therapy Protocol. So definitely check that out to learn a bit more. That is it for today's podcast. Thank you for joining. On the next one, we'll continue our talk on our case study after ACL reconstruction. Stay tuned.